Good afternoon, everyone. Now that we've got the boring panels out of the way, you guys ready for some exciting stuff? Thank you for joining us for this conversation about the future of medical education. We're training the physicians of 2030, 2040. And medical schools really haven't changed that much in the past century. Usually you take about 18 months to 2 years doing what we call pre-clerkship, that's classwork. And you take another 2 years to do clerkship, where you're actually in the labs, in the hospital or in the OR, training underneath other physicians. So how do we evolve so that we can start to accommodate these new technologies, these new ways of delivering medicine? We're no longer delivering medicine only in the hospital, we're doing it at home, on your cell phone. How do we train physicians for this new era of healthcare? Well, joining me today are two great folks to actually talk about the evolution of med school. I have with me Dr. Horman, the Vice Dean of Educational Programming at McGovern Medical School, and Dr. Scott, the Vice Dean for Education at U of H. I'm going to let them introduce themselves a little bit further, but thank you for joining me on this panel.
Thank you. Great to be here. Pleasure to be back. I'll just mention two quick things. Super grateful to have done my medical training here in the Texas Medical Center at Baylor College of Medicine, an early career on faculty at Baylor. I'm a career educator, took on more and more education over time. And then I've had the privilege of being a part of several new schools and the opportunity to rethink and try out new things in the medical education space. First with Cornell, as they developed a branch campus in the Middle East, in Doha, Qatar, was there for 8 years, and then came back to work with TCU, Texas Christian University up in Fort Worth, also started a new medical school and had the opportunity to be there a few years before the launch, really design and think about that program. And then for the last 2 years, great to be back working with the University of Houston, also a new medical school.
Thanks for joining.
So in contrast, I've done all my training here and I stayed. I didn't go anywhere else. I am a pediatrician by training. I did my medical school and residency here in the Texas Medical Center and have stayed as faculty. And in our role in the schools, we work with the faculty to determine what the students should be learning, how they should be learning it, when they should learn it, and how they're tested on it or how they're assessed. And so it's an honor to be here. I'm very excited to have this little chat.
Thanks for joining me. And as Devin mentioned, I'm the recently minted Senior Associate Dean of Innovation at the School of Engineering Medicine, where we combine a dual degree of a Master's of Engineering and a medical doctorate in students at 4 years time. So a professional with 2 domains. So the first question I have was actually my favorite. If you could redesign one component of medical education from scratch, what would it be and why?
So we've been talking about how we assess students for years. And when I trained, and I don't want to age anybody else, but when I trained, you finished your 4 years of medical school and it was assumed that you've learned it all and you were good to go. And that's not really the best way of doing things. And we've been trying to work on how do we keep track of what our students are learning? How do we see that they can demonstrate that they can do these behaviors? And then we call that competency-based education. And I think that's the biggest thing that I would really focus on. And we have focused on it for a while, but this is probably the thing that I would blow up the most if I had to, is really get a better idea of what the students are learning and having them demonstrate to us that they can actually do the job rather than just assuming that they're done in 4 years, that they have figured it out.
I would just build on that by saying, mentioned some of the traditional structures that are sort of time-based, or it's a proxy for some of that learning that Mark was talking about. We have opportunities and ways to really individualize that, and then also to continue to ask the question, what does a student need to know to be able to make an excellent clinical decision? So it's required constant reevaluation of what we teach. I would say 25 years ago, there was a long biochemistry course that often was a part of our curricula. Some of that's really important to know to make a clinical decision. Some of it may be more important to know if you're going to have a research career or do some other things. And so really, again, clarifying what does that physician, and now, what does that physician of 2030 look like? What skills do they need, and how do we ensure that we're equipping them to be effective in the future?
Awesome. I was thinking about this question, and of course, immediately I go to technology or engineering, but the more I thought about it, have you guys, who in here is a physician? Raise your hand. Oh, only a few, okay. As a physician who's never been a patient, you're missing sort of the customer experience, if you will. So I was thinking about, what about if we just brainstorm real quick on stage? A rotation where the students are sort of forced, that's probably not a good word, or intend to experience the patient's perspective. They're admitted to the hospital, they're treated as a patient would be treated, they're seeing how the nurses work with the technicians, how the physician sees them for only 5 minutes a day. What do you guys think about that?
So in my TCU experience, one of the things we talked about at length and really impacted our design of that curriculum was the concept of empathy. How do we help young students really develop skills to be able to demonstrate empathy? We know these are trainable, these are developable. We can all grow and get better at them. And so designing experiences right along those lines to give them the opportunity to think about what it's like to walk in someone else's shoes, to articulate that, and then use that as information to help them develop the skills that they would hope to see.
I love that.
Yeah, it's all about perspective. And if you're a student who's just graduated college and you're in your basic science part of medical school, it's easy to forget what the end goal is. And making sure that they have that experience where they actually see themselves on the other side. What is the patient seeing? We want to make sure that they really have an idea of the patient's perspective. And we, just as an example, in the hospital, somebody has a seizure. Well, we see that all the time. We're coming in, making sure they're breathing okay, but the parents, I'm, again, a pediatrician, parents are freaking out because their kid's having a seizure. And that's something that, until you really stop back and think about it, the residents and students don't think that way. They think, oh, we're in the hospital, we can control this. And so what we really try and do is get them to understand from the patient perspective that this is very different. It's a very foreign environment to the patients when they're in the hospital or in the clinic. And so you sort of force them to move in that direction. Now, you were talking about an actual rotation.
Yep.
I don't know whether any of you, it's an older movie, it's called The Doctor with William Hurt. And towards the end of that movie, he actually has a bunch of students and residents come into an empty ICU and sets them up. Okay, you're about to have a barium enema, you're gonna have this, you're gonna have that. And that's a
Wait, did you say barium enema?
I did.
I just want to make sure you guys
Yes, I
heard that.
You just want to make sure that was out there, yeah.
Wow, okay.
But that was one very direct way of doing that. We don't do that, but we do try and make sure that the students understand it from the patient side.
I think it might hurt admissions if we said you have to have a barium enema or a colonoscopy to be part of
Yeah,
it.
that right.
Maybe so. As care increasingly shifts from the hospital to the home to virtual spaces, how should we as educators evolve so that our students are prepared to deliver medicine in those new environments?
So one of the, I think, things maybe to make transparent for those that aren't close to medical education, over the last, I would say, 20 years, most medical schools now put students in clinical settings from the very beginning. You have clinical experiences from that second, third week of medical school. Some of the clinical skills training that Mark was referring to, so that they have the opportunity to see how care is delivered, to begin to develop their own communication skills, physical exam skills, diagnostic skills, all those things. And those care experiences are happening outside of the hospital. One of the things we've done at University of Houston is develop a household-centered care course where students actually participate on an interdisciplinary team. They go out to a home. They're thinking about things like structural barriers to health or determinants of health, thinking about the impact, and then also providing clinical care. But I think with the advent of many of the technologies that you all are working on, ensuring that we, again, are identifying what those skills are. How do you conduct an effective telemedicine visit? How do you look at the data you're getting from wearables? Or how do you look at data at a population level for a community that you're working with to identify and implement potential solutions?
Makes sense.
I think one of the good things to come out of the pandemic was there's more of a ability to do telemedicine now. I think that telemedicine was always around. We had been doing it in the Valley for about 20 years. But once COVID came along, it became much more of a thing and much more accessible because a lot of insurance started paying for it. And so that's one of the things that we started teaching our students. How do you do a telemedicine visit effectively? You can't listen to the lungs or heart through the connection. You're basically getting a history and then looking at the patient. And so it's limited. But we want to make sure that the students understand those limitations, understand when, okay, this isn't enough and you do need to come in, or whether it is enough and you can make care decisions through telemed. So it is important that they understand that there are other options to actually having somebody come see you. We also have our students go out in the first year to visit patients in the field, in their environment, because again, it's about perspective, making sure that students understand that.
I'm going to go off the script a little bit, and just a question came to mind when you were talking. Students are, in my opinion, demanding more and more from an educational experience. I want to learn about healthcare economics. I want to learn about entrepreneurship. I want to learn about health policy. I want to learn about engineering. What do you think about these combined degrees or adding additional information on top of an already robust and difficult course that is medical school?
And this, to expand on that, a lot of students feel pressure to distinguish themselves in some way as they're applying to residency. So there's more of an interest in doing additional things outside the core curriculum of medicine. And some students can do that, and some students can't, and they become unsuccessful at their main job, which is getting the MD. And so there are a lot of dual degree options that schools have now. You can get an MBA along with the MD. You can get a Master's in Science. We have an informatics school at the UT Health Science Center, and so you can get an MS in informatics or artificial intelligence. But we do remind the students that at the end of the day, you came here to be a doctor, a physician, and that this other stuff, while interesting, needs to make sure you understand the priorities. And sometimes students will understand that, and they'll actually take a year. We're seeing more students taking 5 years to finish medical school, with one of those years being a year where they're working on a master's degree or something else. And so for the students who really have this external interest, it is great for them to have that opportunity, but we do want to keep an eye on the students who might struggle with that and make sure that they understand their priorities.
Yeah, 100% agree. And then to build on what Mark said earlier about some of those competencies, within the core curriculum itself, there are things like systems-based practice. So some of those elements about how health systems are financed and the delivery of healthcare that are part of the required curriculum. So students are learning, even in that core curriculum, about some of these issues. It's not just diabetes and hypertension.
And to your point, students usually have a lot of initiative at schools. They usually have the ability to set up their own electives. They can set up teaching sessions with other faculty. We have, I think at last count, about 120 different elective opportunities for the students. And so the students do have some initiative and some agency there, and they set things up on their own when they're interested in something.
Yep.
How do you feel about preparing students for the healthcare system that's going to be the future, as opposed to preparing them for the healthcare system that exists now, when most of us have no idea what's going to happen in the next 10 years? How do you think about that in the course of educating your students and sort of imbibing them with a flexible mindset, I guess?
Yeah, I think it's a key question. I think we're all grappling with what that physician of 2030 looks like. We already know that even today, you essentially can have the knowledge and clinical reasoning of a physician in your pocket. So we are working to figure out what skills, say, do students need around AI? What does AI literacy look like? How do they understand what the tool is, how to use the tool, some of the ethical and other parameters to know when it's appropriate to use the tool and when there are safeguards or things that need to be thought about. So yeah, I welcome Mark's additional thoughts here.
It's really hard to predict what they're going to need. And so what we end up focusing on is flexibility and making sure they are resilient and they're prepared for future states. And we're upfront with them. We don't always know the answers. But medical education has changed over the years. The electronic health record has significantly changed how we teach things. I used to write orders on paper, and now they're all electronic. And so we don't teach the students how to write orders on paper anymore because they don't do it. One of the things we're debating now is we teach students how to document their encounter with writing up their history and physical. But there are systems that will listen to the encounter and parse it and put it into a format so the student doesn't have to do anything but edit it. And so, what do we teach there? And the other thing with that particular technology is that it's very expensive. And so do we buy it for all the students and all the residents and all the faculty? If we don't buy it for the students, how will the students know how to use it when they're moving into residency? So these are all the things that we're struggling with now.
Do you think? Oh, go ahead.
If I can have one thought there. So one thing we've always really attended to, Mark alluded to it by saying, the content and knowledge in medicine is always changing. And so we have always been very intentional about ensuring that students develop lifelong learning skills. I think that's as important as it has ever been, and I think will continue to be something that occupies a good amount of our time. How do we equip them to learn the things they need to learn throughout their career?
Many of our audience members are probably startups or work with startups. What kind of advice would you give to these innovators about working with students or thinking about working with students?
I think that students are very goal-directed. And if it's relevant to the test they're taking next, they're very interested. And if it's not, they're less so. And so making sure that there's evidence of why this is important, why they should be using this platform, or why they should be doing this thing. They're very goal-driven, and they want to make sure that this is useful to them. We struggle with that in how we teach them, because we'll sometimes teach them things that aren't relevant for the test this week, but are relevant when they're practicing. But it's hard to sort of frame that to understand. And the other thing is, when we're looking at new technologies in education, technology is cool, but what's the outcome? How are you making the student better? Or how are you making the patient care that the student's going to provide better? You know, throwing stuff up there and using technology and 3D imaging and things like that, it's neat. We look at that for anatomy. How are we teaching anatomy? So there's some 3D imaging platforms for that. But at the end of the day, how are you making the student a better physician? And how is that translating into better patient care? And that's the end goal for all of the things that we look at as far as technology goes.
Yeah, I would just add that students are very eager. They're very curious. I think engaging students in the development of a new tool or a new product or a new idea, they are very interested and excited about that. So when you have opportunities to engage a student in that work, it's incredibly valuable.
And they are pretty smart people. Some of the things our students come up with are incredible. We're just really impressed with them. And so giving them an opportunity to provide ideas, I think, is a great idea, yeah.
All right, I have 3 minutes left. I'm going to throw one hand grenade question to you. When I was going through medical school, there was a lot of complaints about you're losing the art of medicine. People or students are no longer able to do good physical exams. I can see that only getting worse, especially with the advent of AI. Do you guys think we're losing the art of medicine?
So I'm convinced that medicine will always be about humanity. It will always be about applying all of this data and evidence to the person sitting in front of me. And I think we'll all want to know that that communication with us is really grounded in who we are as individuals. It incorporates our goals for care, our goals for health, what we value. And I think there will always be a core element of a person in that conversation, even if it is augmented, say, by a screening AI-based interview or something that drills down to the thing. So I think we have to equip our students to be that thing that I think AI will not replace.
Completely agree that over the years, the tools change, the tools that the students have available to them to assess a patient, but you're still having that relationship with the person, with the patient. You're still talking to them, you're still reassuring them, you're still educating them, and that's not something that I think can be completely replaced. And so the physical exam may change, some of these things may change, some of the tools to get the job done may change, but I think at its core, as you said, it's really about that relationship.
Well, thank you all so much for your attention. Let's thank our panelists, Dr. Scott and Dr. Harmon, for a great conversation.
Thank you. Thank you all. All right.